in extension. Okay? We know over time, if you're in that pattern for long enough, we have connective tissue changes, and it becomes not only a neuromuscular type pattern we have to change, but also a connective tissue type pattern we have to change. So hence you can gain from that, well, I need to have some type of technique to change the neuromuscular component, but I also had to have a connective tissue type technique to change that component as well. So basically the older we get, if we're in that pattern long enough, and Andrew just showed us this morning that neuromuscular patterning is more or less time dependent, so you spend the more time you spend in that position, the more motor patterning you do get within that position. Okay, so that's flexed and extended lesions.
Right, sorry. If you had someone with a unilateral extension or flexion lesion and you were testing them just in a pure flexion or extension, what would they generally feel like? Would it be a
Nothing.
muscular restriction, or they wouldn't be able to go further?
Because a lot of people, this has happened over such a long period of time, they consider it normal. And you'll see people that will bend, and when you say you're actually bending quite markedly you're rotating to your left quite markedly, they'll say, I am, and they don't recognise it. You can actually apply treatment techniques to correct that, and then they'll say, oh, what have you done to me? That feels bizarre. Although to us, it looks visually a lot more normal. So because it happens slowly over time, their proprioception subtly changes from day to day, and they continually perceive that as normal. Yeah.
Making that correction, does that make a difference to other tissue that's adapted to that?
Huge changes, and that's why it's...
And then could be a negative though, you know what I'm saying?
Absolutely. That's why the more chronic it is, the more care you have to take with regard to client education. So if you've got someone that's like 65 like Andrew, so you have to take a lot more care, because obviously there's a lot more connective tissue changes and there's a lot more neuromuscular change. So hence, the way he reacts to treatment in comparison to, say, a 22-year-old, I mean, isn't it great when a 22-year-old walks in? Because you can more or less just do just about anything and you make a change, and they don't come back and you think, well, I mustn't have done any good with that person because they didn't rebook. But they'll down the track see you at the coffee shop, say, that was fantastic, I had such a great result and it's never come back. It's great working with those, the adolescents and the kids and the young ones, because they don't have that chronic connective tissue and other type of tissue changes. So yeah, absolutely. A lot of feedback to the client. Does that answer your question, BJ? All right, so thoracic spine, what do we concentrate on the thoracic spine? Your cervical spine and your lumbar spine are very mobile structures because they don't have those, in comparison to the thoracic spine, because we don't have ribs, okay? Very easy to change a lumbar spine position, very easy to change a cervical spine position. Can become extremely difficult to change a thoracic spine position because of the ribs, those three joints throughout each section, plus they join obviously onto your sternum as well. Okay, so when we're trying to change someone's overall position, postural position, scapulothoracic position, glenohumeral joint position, we often go to the thoracic spine for that reason. It's quick and easy to change lumbar and cervical, all right, but it's that all those joints which make it more important to have a look at the thoracic spine and make sure it's moving as good as it possibly can, and you'll find that lumbar spine and the cervical spine will just consequentially change in a hurry. Okay? And Carly, you can disagree at any stage. So what typical sitting posture, I know a lot of people have seen this, I keep throwing it up because I think it's a really nice, quick little visual that you can, I know a couple of our guys have got it printed off, and I've had it stuck on my wall for 10 years so I could quickly show people, clients that is, what goes on when they sit in a particular type of posture, and just point out the upper cervical extension, which obviously gets a closing down of the facet joints. The facet joints get irritated. When you get an irritated facet joints in the upper cervical spine, you get all types of headaches and referral patterns. You get that lower cervical flexion, so the joints are open. Okay, C5-6 is the most mobile joint with regard to flexion extension, so it's working overtime. C6-7 as well, not as much. So when it's open, everything's holding on, the musculature which is trying to hold that joint so your head doesn't fall off, goes, well, bugger this. So your body says, I'm going to lay down some connective tissue to help hold that structure, to take the load, so you get a big build-up and the Dowdy's hump and so on. So this is the sort of, I wouldn't express it in that sort of terms, but layman's terms to the client. Ligamentous strain over time and ligamentous, the increase in length of the ligaments throughout thoracic spine. Obviously the hyperkyphosis, and that's extremely important. If you're dealing with a glenohumeral joint pathology or pain, or you're dealing with a scapulothoracic issue, you can't address these two without addressing thoracic spine. It's ridiculous. All right? We know that the scapula is gravity driven. Doesn't matter how strong your retractors are or how tight these are. If you're in this position, you can do retraction exercises all day long. It's gravity driven, so unless you've got your thoracic spine in a neutral position, your scapula will not change. It's gravity driven, so you've got to have your thoracic spine in its ideal position to address that scapulothoracic position, and then the last thing you do is get back to your glenohumeral joint, because we know there's no use trying to retrain a glenohumeral joint in this position by doing external rotation exercise. It's a waste of time. Yeah? So thoracic spine, scapulothoracic, then your glenohumeral joint. So hence your thoracic spine, extremely important. And I always go on about there's no use trying to change this unless you change the pelvis. I challenge anyone to be in a big posterior tilt and then try to have a thoracic spine neutral. Okay, so always start with your neutral pelvis position, gives you a nice lumbar curve, and then consequential changes throughout the chain, which we'll have a look at in a second. This is just a little list of how to convince your client that it's really important to have postural changes. You know when you tell your client you've got to do posture this and posture that, and they just do that sort of thing? And you can tell they're not listening, they tell you're not going to do it. So a couple of little cues that, again, I know some people have done the extended workshop, they've seen these, hopefully it's just a summary, is to go through some cues to convince them that it's necessary to get out of that posture. All right? So I'll just quickly, can I steal that chair? So the first thing is, obviously, oxygen's pretty important, and oxygen only comes from taking breath, so we need to get as much air into our lungs as possible. So I get people to posteriorly tilt and slump. So I'll get everyone to do that for me now. Now, without changing that position, try to take a deep diaphragmatic breath. All right, obviously quite difficult. Bring your pelvis into a neutral position and now take a deep breath. And it's pretty obvious, I don't have to tell you the difference. You can see the change that makes. Secondly, in this position, often with these people, we're talking about what is occurring with their thoracic spine and how that's consequentially affecting all these other structures. Now, if you're in this position and you're breathing, what structures are you using to breathe? All right, so we're using all this accessory stuff because we've got a complete inhibition going on through posture of our diaphragm, yeah? So in this position, we can actually use our diaphragm. In this one, we can't, so we've got to use our accessory. What happens when we use these accessory muscles? Close down space for the neurovascular bundles. First rib starts popping up. We get all those biomechanical changes due to poor posture. Okay? So one, that's just for you guys. There's no use telling a client that because I'll go, all right? But the breath one, you can convince them. Take a deep breath. Can't. Take a deep breath. I can. All right, and secondly, for those who have shoulder issues, get them to posterior tilt. So everyone do that for me now. I want you to externally rotate as much as you can. All right, pretty ridiculous, isn't it? Anterior tilt or neutral tilt. Now externally rotate. So it's pretty basic. So it convinces them that when you're in that position, you can't get your scapula into a neutral position and you can't externally rotate. All right? So there are a couple of the quick cues that I like to give people to convince them that posture is necessary, absolutely necessary, and therefore they're more likely to go home and complete the exercises. Cervical range of motion, when you're in a posterior tilt, most of your cervical rotation comes from your upper cervical spine anyway, but it's pretty handy if you do get the available rotation through those other facet joints as well. Otherwise you completely overload a couple of facet joints, they'll eventually become irritated. Okay? So in this position, all upper. In this position, at least you get some lower cervical rotation as well. Posture, and that posture is all available to us if we've got a mobile thoracic spine. So acute factors and the chronic factors, which is if you've got someone that's really keen to know, then you can tell them this sort of stuff, but it's more for us. As I've suggested, the longer you're in that position, the greater neuromuscular change, the greater connective tissue change, resting muscle length change and so on, and the ability to contract. So you get a lot of people that still might have the available range to get up there, but because they've got a complete change in their muscle length physiology, then they can't hold themselves there long enough because their conditioning is so poor. All right? So that's, like Andrew was saying this morning, it's all about creating an environment where they can utilise their capabilities to the best of their ability. Yeah? Skipping through a bit. All right, so the cues that I like to use, BJ, can I use yours, please, mate? Park your bum. So what cues do I like to use? I don't like to use 16 degrees for sternal angle and 17.2 degrees for sacral angle and all that sort of stuff because we're not all the same. So I like to make it more functional. So for me, the moment you've got stability muscles turning on, it means that area is stable, and that's what we're after. Right? We're after a stable environment. Okay? So one way to convince people, I'm going to get everyone to do this in a minute, just go forward on your seat a bit. Go into sort of your dad's posture when he's watching telly. All right, bum forward on the seat further. Your dad never sits like that. There you go. All right, so you've got this going on. So you've got a big posterior rotation. So when we posteriorly rotate through our pelvis, our multifidus is not doing anything, is it? It's completely turned off. And you'll see that in a minute when you all practice this. So we've got an unstable environment.